Mr. Joyner, before the COVID vaccine, what was the highest grossing drug of all time?
I'm sorry, before the what?
Mr. Joyner, before the COVID vaccine, what was the highest grossing drug of all time?
Humira.
Humira. That's because for 20 years, Humira was the only option for rheumatoid arthritis patients. People didn't have cheaper alternatives, and they literally ended up paying the price, and that price without insurance was a whopping $7,000 per month. And before you decide to put all the blame onto AbbVie, the manufacturer of Humira, I will remind you that I had some choice words for AbbVie's CEO. So, Mr. Gonzalez, you're spending all this money to make sure you make money rather than spending money to invest in, develop drugs, and help patients with affordable life-saving drugs. You lie to patients when you charge them twice as much for an unimproved drug, and then you lie to policymakers when you tell us that R&D justifies those price increases. But good news, in 2023, Humira's patents finally ended and cheaper biosimilar drugs came on the market. So, Mr. Joyner, by the end of 2023, how much of the market did Humira's competitors control?
Less than 1%.
Wait, you're telling me that patients had the option to get a much cheaper drug, and almost everyone wanted to pay more money to get Humira? Make it make sense, Mr. Joyner. Were the biosimilars not as clinically effective?
No, it's a great question, Congresswoman, and generally speaking, the products that came to market initially were priced more like brands. So we actually was part of working with another manufacturer, bringing a product to market that was actually 82% less than the list price of Humira. And in April of this year, we actually removed Humira, the most successful product in the country, from our formulary. We converted 97% of that volume. In fact, in just 3 weeks' time, we moved more market share than all was dispensed in 2023.
Mr. Joyner, that's remarkable. Why did it take a year and a half?
We believe because...
Was it because you were waiting until you could manufacture your own version of Humira called, I believe it's Hyrimoz?
So we actually brought a product to market in April because that's when we believed that there was enough manufacturing capacity.
April of 2024.
Correct. We saved 50% off of the 2022 spend, $500 million worth of savings for our customers, and the patients were basically paid $0 out of pocket. So it was a really great success story.
There's no doubt that Humira having competition has been a good thing. But you waited over a year from when the Humira biosimilars became available to put them on your drug list. Yes or no?
So not a year from when the Hyrimoz product was introduced.
No, let me repeat the question. Let's try to get an answer. How long did CVS, yes or no, Caremark, wait a year to add Humira biosimilars to their drug list?
No, we added biosimilars to our drug list in 2023. We didn't remove Humira until April of...
So a patient would have paid the same for Humira and the biosimilars at that time?
They would have also had copay support, so they could have had gotten the benefit of a $0 out-of-pocket cost.
How much did CVS receive in rebates from Humira's manufacturer, AbbVie, in 2023?
I'm not certain.
Mr. Chairman, I ask unanimous consent to enter into the record a Kaiser Family Foundation Health News article titled, "Save Billions or Stick with Humira, Drug Brokers," that would be you all, "steer Americans to the costly choice."
Without objection, so ordered.
So that article says that Humira's rebates were at least 40 to 60% of the drug's list price in 2023. Does that sound right to you?
It's in the ballpark.
Okay, so let's use the low figure of 40% being the rebate off the list price that you negotiated. This is your value in the marketplace, correct? Negotiating this rebate. How much did Humira generate in sales in 2023? Do you know?
I do not know.
14.4 billion. What's 40% of 14.4 billion?
So 52?
Pretty good. Pretty good math. $5.6 billion. Did all that money that you got as a rebate, did it go to patients?
The rebates were passed through to our customers, the employers, the organizations that fund healthcare in this country, and then they use those dollars, in some cases, to actually pass it on to the members.
You didn't retain any of that rebate?
As we mentioned in my opening statement, CVS Caremark retains, passes through 99+% of all the rebates that we negotiate with the manufacturers.
Look, I think here's the problem. Pharmacy benefit managers today are the worst kind of middlemen. You stop competition, you prevent transparency, you manipulate markets, and you make our healthcare system more complicated. Dr. Kutzner, you said healthcare is hard. No. The practice of medicine is hard. Healthcare is just a profit center in this country. I yield back.
I do have really just question, and it is really a yes or no, and I promise, like, you should know this, but did you all make more money in this year than you, I mean, like in 2023 than you did in 2022? Like profit. Did you make more money, Joyner? Did you guys make more money? Are your profits going up, yes or no? Is it?
In 2024, my profits are going down from 23.
It's going down right now?
Yeah.
You're not making any money?
No, we are making money. I'm just
But
saying
it's
if you're
down
talking
from
about the growth.
2023?
Yes.
Interesting. How about you, Kastner? Katzner, is that how you say it?
Yes. So the Cigna Group's profits, as we report, did increase from 22 into 23, and for the first quarter of 24.
So you're doing good. Okay, how about you?
Yes, OptumRx earnings increased from 22 to 23.
By a lot? Is it like doing really well? I don't understand how you're making money and making profit if you're trying to lower costs on our residents. I'm just confused how you can do both. I know my colleagues are not going to get into it, but how do you do both when you got to be making money from somewhere?
And do you believe that that constitutes a taking?
Congressman, again, it's not an area that I specialize in.
I guess I don't understand how, being the Assistant General Counsel, you can come before the United States Congress when you're suing the United States government saying that we are taking your property. I mean, that's a very serious charge. I think it is shameful what you and the pharmaceutical companies have done in suing the United States government to protect those profits, and you are totally unprepared to answer a single question about what the takings clause is and a justification for that lawsuit. I mean, I really believe hopefully someone in the company and these other pharmaceutical companies can provide the American people with an explanation why you consider Medicare negotiating those drugs to lower those profits, those obscene profits, a taking when you don't consider that for the Veterans Affairs Administration or Medicaid.
Dr. Conway, what was your compensation? I'm sorry, I was not in the room when this happened. Did you state what your compensation is?
I was the only one to answer the question. My base salary is $950,000. I believe the question was total compensation.
Total compensation is how much?
Total last year was a little north of $4 million.
$4 million, okay. And Dr. Kautzner, how about you?
So, Ranking Member Raskin, the Cigna Group reports our top 5 highest paid executives in our annual report. I am not one of them. I'd be happy to follow up with you offline.
Oh, that's too bad, but what was your compensation last year, not the top 5?
As I said, I'd be happy to follow up with you offline.
Wow. All right, Chairman Comer, what was your compensation last year as a United States Congressman?
Same as yours, 174.
174,000. Congressman Sessions, how much did you make as a congressman for the United States House of Representatives last year?
Including, I'm half paid. I retired and came back, so half is about a pension of 22 years, and then half is the remaining. So I'm trying to be honest about that.
Yeah, I wasn't aware of that particular mechanism.
Yeah, they net you. I can make no more than $174,000, but half of it was a pension from serving 22 years.
I got you. So, but your take home would be $174,000.
I'm not allowed a penny more.
Well, thank you for laying that all there out in public.
But you asked.
Dr. Keltner didn't want to do that. Mr. Joyner, how much was your compensation last year?
So CVS Health has a top 5. They publish the top 5, and I am not part of the top 5 compensated employees.
All right. What was the bottom 5 of the top 5 at your company?
I am not aware.
What was the top 1 of the top 5?
I think as reported earlier, I think it was $20+ million for our CEO.
20 million was the highest paid
That was
person.
what was reported earlier.
Okay.
I can certainly confirm that.
All right. Well, there's a lot of money being made out there, and a lot of pain and a lot of hardship. You know, your companies are taking a huge chunk of money out of an already staggeringly expensive and inefficient system, a system so convoluted that most people don't even know that your companies exist. And so a lot of people are profiting from the opaqueness, the complexity, the convolution of this healthcare system. And we really have got to clean it up. And I wish that you guys would be part of the solution to help people understand.
Please tell me why you think it is appropriate to charge Americans 9 times more for the same exact product that you sell in Germany. And by the way, correct me if I am wrong here, but I assume that when you sell Ozempic for $59 a month in Germany, you are making a profit there. Am I correct on that?
So, Senator, let me start by acknowledging and sharing your wish to have affordable medicines for Americans. And there's been a number of numbers mentioned here, and I think it's important to say that these are not comparable data. When I mentioned that it's really, really important for us to secure access to patients and affordability, we are hard at work in making sure that patients have access via the insurance schemes. And today, 80% of all Americans with insurance have access to these medicines at $25 or less for a month's supply. So it's a price point at the pharmacy counter we have to talk about.
Let me just interrupt you if I might. Okay, you're correct that many people pay $25 a month for Ozempic, but what you're forgetting to mention is that many of those people are paying outrageously high prices for the insurance that covers Ozempic and other drugs. So simply this is a pass-through to the insurance companies. Bottom line is you are charging the American people substantially more for the same exact drug than you are charging people in other countries. And my question is, why?
So, Senator, I appreciate the question. Let me try to explain how I see it. We launched Ozempic in 2018. We have had it on the market for some years. During those years, our price has declined by 40%. I mentioned that patients with insurance have access to the $25 or less for 80% of the cases. And if you look in this period in Medicare where there's broad coverage, premiums have not gone up. In the same period, the insurance companies and their PBMs, the big conglomerate of legal entities they have more than doubled, actually close to tripled their profit. So the fact that we can actually secure that 99% of people with insurance have access, that there's a copay at the pharmacy of $25 or less without premiums going up in Medicare, while profit goes up for the middlemen, I think is a concerning data point.
Well, I would simply say that most Americans would be surprised to learn that insurance rates are not going up. In my state, they're going up by 14%. But once again, you are not answering my question.
Thank you, Chairman Comer. Chairman, I do want to help support all the text messages you got. I actually got letters of independent pharmacists who say they do not have great relationships with their PBM. One is from independent pharmacists in Flint, Michigan, another who owns a number of independent pharmacies in the Upper Peninsula in Michigan.
Without objection, so ordered.
Each of you have noticed, have said that you have business plans or processes and methods in place to help lower cost for our residents. Yet it has been well documented there has been a huge reduction of pharmacies in many vulnerable areas. One of the things that I know, are of course the DIR fees and reimbursement. But one of the things in the report, and I know you all saw it, but in there, it talks about the post-sale adjustments. Get this, Chairwoman, and Chairwoman McLean and I come from the same state, but check this out. Post-sale adjustments can require a pharmacy to often blindly make payments of hundreds of thousands of dollars back to PBMs months after the relevant prescriptions are sold. So this is like one of my residents going in, and they buy $5 worth, I don't know, dairy products or something like that, like I think I used the example of a gallon of milk. Goes in, buys a gallon of milk, later sees a charge of $5 extra, like after they left the grocery store. So quoted in the report, it says we're often talking about PBMs charging hundreds of thousands of dollars. These are not small fees, though. So the FTC report noted that one of the metrics PBMs often use is, it's really interesting, deciding whether or not to charge pharmacies retroactive fees. These are, again, they left, they paid for it, you all came back and charged them more. It's crazy. Is adherence to medication. I kid you not, Chairwoman. It says, but there's many reasons. So they say that basically the post-sale adjustment is based on whether or not like they're punishing them because a patient is unable to afford their medication, or when the patient cannot pick up the medication on time, that they have an unpredictable work schedule or something, whatever it is. It's some weird little factor you guys are putting in reasons that might all of a sudden say, well, we got a post-sale adjustment. How many of you use post-sale adjustments? Mark, you guys use post-sale adjustments?
No, that program discontinued in 2023.
How about you, Katzner?
Congresswoman, we don't engage in clawbacks.
Yeah, how about you?
OptumRx does not do clawbacks or charge DIR fees.
So what is this thing about you all doing the thing about using to determine whether or not to charge pharmacies, whether or not how removing like the patient adherence? How many of you use that factor? That the patient adheres, how many of you? Katzner, you look like you're interested in this question.
So, Congresswoman, the DIR program expired last year, so that's not
but do you at all determine post-sale adjustments or anything? You don't do any of that anymore?
We don't engage in clawbacks.
Okay, you call it clawbacks. Is that what you guys call clawbacks? Post-sale, like you add, so if any of your independent pharmacies, they walk out and you guys don't go back and say, oops, you owe another $10? None of you do that?
That's not a practice that we're engaged in.
Okay. What is this about a factor using a patient adherence from factors being used to determine whether or not, like, what is that about? Like, the patient is using it. I'm being serious, you guys. This is something in the FTC report, so I'm just curious. Did you guys stop it because they caught you, or what's going on here, or you guys changed the name of it?
So that was the DIR program was actually removed from, it was a government decision. It wasn't a decision that
we forced you guys to do it?
It was enacted by
Yeah, we forced you to do it. What else should we be forcing you guys to do? Because it's still, I'm being serious. You know that you're in the practice, if you're making profits continually, it's not reducing the cost on our residents. Something's wrong. And when I hear from independent pharmacy, I mean, you hear this. I had one in my district, Chairwoman, last thing. He paid like $100 or something right out of pocket. He never got reimbursed for it, ever. He said, because again, whatever you all are doing, it's putting them out of business. And guess what? That means less access to our residents that really depend on independent pharmacies. But again, it sounds like we need to do some forcing them to act in good faith. Sounds like we doing the DIR. If we stop those programs, what else do we need to stop so they can treat everybody fairly and not monopolize as well? I know you guys do that, and you don't offer everybody the same service, and that's ridiculous. With that, I yield.
Thank you, Mr. Chairman. Ms. Ween, what drug does Imbruvica, what does it treat?
Congressman, I recognize Imbruvica is one of the products that we do market. I'm not exactly sure.
It's okay. I'm not trying to trick you. It treats leukemia. Do you know what the price that Johnson & Johnson has set for it?
I do not have that on my fingertips.
It's $484 per capsule per tablet, which works out to about $14,000 per month, which works out to about $160,000 per year for leukemia patients. Now, do you know, or I can tell you, how much money, gross revenue, the Johnson & Johnson has made from this drug over the last 10 years?
Congressman, it's not something that I'm an expert at, not something
Sure.
I'm here to testify to today.
$22 billion. Do you know the gross profits of Johnson & Johnson in 2023?
I couldn't tell you that.
$65 billion. So just to recap, you've got a pill for leukemia patients. You sell it at $484 per capsule. That's $160,000 a year. You've made $22 billion over the last 10 years, and you're making $65 billion in profit. Now, we have passed as a Congress, and the President has signed a bill saying, you know what, let Medicare negotiate to try to bring that price down. And you, in your department, because you're Assistant General Counsel, have filed a lawsuit saying that that negotiation would be an unjust taking. Let me ask you this. Do you believe when the Veterans Administration negotiates for drug prices with you that that is a violation of the takings clause?
Congressman, I appreciate the question. The bases for our litigation against HHS with respect to the Inflation Reduction Act are fully disclosed in our complaint. I'm not an expert in this area.
You're the Assistant General Counsel for a company that is accusing the United States government of taking your property because we're negotiating. And you can't answer a simple question about, I'm just a yes or a no. Does the Veterans Affairs negotiation with Johnson & Johnson constitute a taking?
Congressman, we believe that the IRA constrains
No,
innovation.
I'm not asking about the IRA. I'm asking you about, do you believe the Veterans Affairs, when they negotiate, does that constitute a taking?
Congressman, again, that is not a litigation that I have great familiarity
Okay,
with.
so I'll just say you don't want to answer that question. Do you believe when Medicaid negotiates and gets a rebate for anything over the price of inflation, do you believe that that constitutes a taking?
Congressman, again, it's not an area that I specialize in.
Taking means like if I came as the government with the force, took your property, and you don't know whether it's a taking, whether when the Veterans Administration negotiates, you don't know whether it's a taking, whether Medicaid negotiates. I assume you'd say it's not a taking, because obviously it's not a taking. These administrations have been negotiating for years, and yet you're arguing that Medicare should, when they negotiate, it's a taking. Medicaid, do you know how many % of the American population is on Medicare?
Congressman, no.
It's 18% about. Do you know how many are on Medicaid?
Congressman, no.
About 18%. So it's not like Medicare has a bigger market. Medicaid negotiates with 18%. Do you know about how much is on, how many of our people are veterans? It's about 6%. So you have already a larger population, when you combine Medicaid and Veterans Affairs, negotiating with your company so that you don't make $65 billion in profits every year, and so leukemia patients don't pay $160,000. You have filed a lawsuit. I think it is shameful what you and the pharmaceutical companies have done in suing the United States government to protect those profits, and you are totally unprepared to answer a single question about what the takings clause is and a justification for that lawsuit. Mr. Chairman, I hope someone will answer my questions on that, and I'll yield back my time.
I now recognize the ranking member for his opening statement.
Hey, thank you, Mr. Chairman. Welcome to the witnesses. It's the third committee this Congress, third committee hearing this Congress on the subject, and we finally have the largest PBMs here at the table. Thank you for joining us. Patients say that some of your practices are making it more difficult and more expensive to access the medication that they need, and so we need to hear from you about what's going on. The three companies represented today account for 80% of the PBM market, which means that the three of you sitting here are responsible for the policies and practices that directly affect the lives and the health and the pocketbooks of 270 million people in America, most of whom are not even aware that your companies exist. People don't choose their PBMs. People do choose a health insurance plan, which in turn has a PBM. Most people are offered a choice between a small number of health insurance plans, and then they wade through somewhat confusing language and murky distinctions to find the one that they think is best suited to the needs of their family. Nobody is thinking about the PBM that accompanies the health plan they use. In fact, most people don't even know that the health plan they're selecting is going to be working with a PBM. No one is considering the health insurance plan that they spend hours trying to select is closely affected not just by not just by the insurance company, but also by another enormous business looking to profit. Although PBMs operate way outside of public consciousness, your companies have immense power over patients. PBMs create the list of medications that determine what will and won't be covered by an insurance plan. They determine how much those medications will cost, and they determine which pharmacies a patient can or cannot use to access the medications. Your three companies are dictating these terms for 4 out of 5 people in our country. And I'm glad you're here with us today to provide serious, robust insight into these decisions. While we don't have a lot of visibility into the inner workings of PBMs, the work this committee's done on PBMs this Congress has provided many examples of how your policies are not necessarily always working for the people that are served. The New York Times recently reported that one of your companies was charging patients on Medicare more than $650 for a medication that would have cost less than $50 at an online pharmacy without any insurance at all. A different patient was reportedly charged $211 by one of your companies for a drug he could have acquired at Costco for $22. That's a 10-to-1 ratio between what people are paying through the PBMs versus what they could get in just an out-of-pocket purchase. Who do these policies benefit? Well, obviously not the patients. It seems they benefit the PBMs, which get reimbursed by the health insurer for that higher price. Even if this system works for some patients, it's clear that many served by your companies are falling through the cracks, whether they experience delays in getting the medicine they need or they're forced to overpay. In a for-profit healthcare system, we know companies are going to seek profits, but it's unacceptable for those profits to come at the expense of patients getting the basic medicine that they need to lead their full and healthy lives. Democrats on the committee have long worked to hold Big Pharma accountable for the ways in which they relentlessly manipulate the price of medications and make them unaffordable for tens of millions of Americans. Our 3-year investigation revealed that pharmaceuticals use anti-competitive tactics to stop generics from entering the market and to target the U.S. for high prices because our government simply did not have the power to directly negotiate with them the way that our peer countries do. But last Congress, Democrats passed the Inflation Reduction Act, and the wins from that landmark legislation are already being felt. Beginning next year, Medicare will negotiate drug pricing directly with the pharmaceuticals, and drug companies will now have to reimburse the government when they raise prices beyond the rate of inflation. But we have a long way to go to place people over profits, to put healthcare first. I hope that today's hearing can shed light on the way that PBMs are taking a page from Big Pharma's practices and exacerbating the drug affordability crisis. We need a healthcare system that is going to work for the people. Thank you, Mr. Chairman. I yield back.
I yield now to Ranking Member Raskin.
Thank you, Mr. Chairman. I wonder, do any of you guys have high school-aged children? You do, Dr. Conway. All right. So don't set this at the elementary school level, because I don't want it to be just you try and help people, but don't set it at the PhD level, but set it at the high school level. Explain to a high school student what the PBM does and what value you render in America's confusing healthcare system. Could you?
Yes, so the way I would describe it to a high school student is the following. We provide lower cost drugs to the people we serve, employers, unions, state governments, others, and we provide accessible, affordable options to people. It's based on clinical evidence on what medicines are most effective, and then we negotiate for the lowest net cost transparently and provide that information both to the customer and to the patients we serve.
Okay, the graphic behind me shows that when combined, the larger healthcare conglomerates to which your three companies belong control 20% of America's national healthcare expenditures, a figure that has been growing substantially. And the three PMs represented today, independent of their parent companies, are so big that you would all fall within the top 40 businesses in America by revenue. And this size means that collectively you control nearly 80% of prescription drugs dispensed in the country. The next three largest PBMs account for 5% of the market, and the remaining 60 PMs account for 6% of prescriptions managed and dispensed, okay? So, Mr. Joyner, let's take you. Excluding the two large companies represented at the table along with you today, of the 60 PBMs that account for just 6% of the market, which does CVS Caremark consider to be, say, its top three competitors?
So there are a variety of competitors, 70-plus PBMs in the marketplace, all competing respectively for customers. This is a highly competitive marketplace, and we basically win and lose based off the value proposition that we present to our customers.
Okay, so who would be the top three outside of the mega corporations represented? Who would be your top three competitors for that 6%?
Yeah, it will depend on the market segment. So there are some Blue Cross Blue Shield solutions that compete effectively within that. So that would obviously be a competitor for that particular segment of the marketplace.
Okay. Would you agree that the PBM should be held accountable to the patients and not just the institutions you represent, or would you disagree with that? Dr. Kautzner, let me ask you.
We're absolutely, Ranking Member Raskin, accountable to our patients. And I think it's important to recognize
Can you explain how you're held accountable to the patients?
Every prescription that we process today undergoes 18,000 safety, quality, and benefit checks in less than 1 second. And with that work, we will prevent approximately 100 million potential medication errors this year. So that's how we positively affect patients. We also
right, but that's different from the question of accountability. So, I mean, the answer could be no, that's not your function in the marketplace, but is there any accountability mechanism between you and the actual patients, or do you just deal with the institutions, the businesses, the unions, and so on that you represent?
So our contracts are with employers, labor unions, government entities, but we absolutely are committed to patient care and health and care coordination. It's why we employ thousands of nurses and pharmacists within our organizations to provide that high-quality clinical care.
All right, can you explain again and put it in clear terms, because a lot of this stuff is hard for people to understand, okay? Why is it that there are so many cases that the committee has found, the chairman has cited them, where people are ending up being charged 10 times more within one of the plans than they would be if they were just to go and pay out of pocket for a drug? Why does that happen? Can you explain that?
So today, for over 80% of patients in America, they spend less than $250 on all of their prescriptions in a given year. There are 1% of patients where challenges still exist, where that 1% may spend over $2,000 annually on prescription drugs. That's the group that we are providing patient savings programs for and working hard to provide improved patient benefit designs so that we can keep costs down in that area.
Again, I feel like the more I hear, the less I understand. I mean, I just have one simple question. If somebody's covered by one of the plans, how is it possible that they've got to pay 10 times more than they would pay if they were just to go and pay out of pocket for the drug. Mr. Jordan, can you explain why that would happen? And I'm willing to believe, maybe that's not the majority of the cases. I think that's what you're saying, Dr. Gelsner. But why, can someone just tell us why that happens, and it can help us understand the dynamics of this market?
Yeah, as I said earlier, there's a variety of different pricing models in the marketplace today. What you're referring to is what generally is an average pricing that we have contracted with our clients. The good news is, and as I mentioned earlier about coming back into CVS Caremark, is I am trying to change and transform the marketplace, which is in large part why we introduced True Cost, which is a price model that actually allows us to guarantee every drug at every pharmacy across 14,000 different medications. So that would, in effect, get you to the consistency that and actually eliminate many of the headlines that you're referencing.
All right, my time is up, Mr. Chairman. Thank you for your indulgence, and I look forward to questioning by our colleagues, including Representative Auchincloss, who's a real specialist in this, and I hope we'll just get some illumination today about some of these strange things we found.
Ranking Member, is there anything else you wanted to add before the end?
Yes, just one or two things. First of all, I want to thank you, Mr. Chairman, for 2 excellent hearings in a row, Monday and Tuesday. We've had a great week so far in terms of our ability to try to penetrate governmental or corporate bureaucracies that seem to be indifferent to a clear public interest. I learned a lot from this hearing, I've got to say, and it's disappointing to me to learn about so many abuses taking place inside the system. And so we should act on this, Mr. Chairman. Again, we had clear bipartisan consensus here that this kind of profit-taking at the expense of patients, which is what the healthcare system should be all about, is really unsustainable. And we hear about it from our constituents all of the time. I understand that's not the principal concern of our witnesses today, despite the protestations that their goal is to save costs. No, their goal is to make money as corporations. That's the way the system is really operating, and that's fine. That's what they're doing. But we've got to protect the American people, and I hope we can act together to really try to reduce costs and make sure that everybody in America can get the prescription drugs that they need at an affordable price. I'll yield back to you, Mr. Chairman.
The issue that we are discussing this morning is not complicated. It has everything to do with the chart behind me, which shows that Novo Nordisk's diabetes drug, Ozempic, is sold in Canada for $155, in Denmark for $122, in France for $71, and in Germany for $59. In the United States, Novo Nordisk charges us $969, over 15 times more than they sell that product in Germany. Wegovy, Novo Nordisk's weight loss drug, is even more expensive. As the chart behind me also shows, Wegovy is sold for $265 in Canada, $186 in Denmark, $137 in Germany, and $92 in the United Kingdom. In the U.S., the list price for Wegovy is $1,349 a month, nearly 15 times as much as it costs in the United Kingdom. What we are dealing with today is not just an issue of economics. It is not just an issue of corporate greed. It is a profound moral issue. Novo Nordisk has developed game-changing drugs which, if made affordable, can save the lives of tens of thousands of Americans every year and significantly improve the quality of life of millions more, if made affordable. If not made affordable, Americans throughout this country will needlessly die and suffer. As representatives of the American people, We cannot allow that to happen. And let's be clear. The outrageously high cost of Ozempic, Wegovy, and other prescription drugs is directly related to the broken, dysfunctional, and cruel healthcare system in our country. While the current system makes huge profits for large drug companies like Novo Nordisk, huge profits for insurance companies, and huge profits for PBMs, it is failing the needs of ordinary Americans. In the United States today, we spend almost twice as much per capita on health care as the people of any other country. Nearly $13,500 for every man, woman, and child, over 17% of our GDP. Yet, despite this huge and unsustainable expenditure, we are the only major country on earth not to guarantee health care to all people as a human right. Further, despite all of that spending, our health care outcomes are not particularly good. Today, over 85 million Americans are uninsured or underinsured. Over 60,000 die each year because they don't get to a doctor when they should, and our life expectancy, which is actually declining in many parts of the country, is far below most other wealthy countries. So what does all of this have to do with Mr. Jorgensen, Novo Nordisk, and our hearing today? A lot. The simple truth is that we pay by far the highest prices in the world for prescription drugs, and that is a major factor in the healthcare crisis we experience. How does that happen? What's the connection? First, 1 out of 4 Americans are unable to afford the prescription drugs that their doctors prescribe. Insanely, that means that millions of Americans go without the treatment that their doctors recommend. The result, some will actually die and others will become much sicker than they should. And millions will unnecessarily end up in emergency rooms or hospitals at great expense to our healthcare system. How crazy is that? Second, one of the reasons that hospital costs, it's not just prescription drugs, hospital costs in this country are rapidly rising, has to do with the very high cost of prescription drugs. In my hospital in Burlington, Vermont, CEO there tells me that 20% of his budget goes to the high cost of prescription drugs. And there are treatments now that cost hundreds of thousands of dollars a year. Third, a significant reason for the high cost of insurance policies. If you're upset out there that you're paying very high amounts of money for your insurance, has to do to a significant degree with the high cost of prescription drugs. Yes, millions of Americans with decent health insurance pay minimal amounts for their prescription drugs. That's the good news. The bad news is that they are paying a fortune in premiums, deductibles, and co-payments for the insurance that covers those drugs. I should also add that if you're a taxpayer in this country, you're paying higher taxes than you should because of the inflated cost that Medicare, Medicaid, and other public health programs pay for prescription drugs. Now, that is the overview and why the issue that we're discussing today is so important. It impacts every aspect of our healthcare system, the federal budget, private insurance. Now, let's get to the particulars with regard to Novo Nordisk, Ozempic, and Wegovy. Ozempic and Wegovy are different brand names for the same drug, semaglutide. These drugs are transformative new treatments for diabetes and obesity that help people control their blood sugar and lose weight. Both are manufactured by Novo Nordisk, and both are on track to be some of the best-selling and most profitable drugs in the history of the pharmaceutical industry. In fact, since 2018, Novo Nordisk has made nearly $50 billion in sales off of these two drugs. Importantly, for members of this committee, 72% of that revenue comes from sales in the United States of America. In other words, the United States is Novo Nordisk's cash cow for Ozempic and Wegovy. And given that these drugs will need to be taken over the course of a lifetime, it's not a one-time drug, you take it for your whole life, Novo Nordisk can expect to receive tens of billions in sales and huge profits from these drugs year after year after year. Now, why does Novo Nordisk charge the American people such outrageously high prices for Ozempic and Wegovy? Are they acting illegally by charging us such high prices? Are they violating the law? No, they're not. What they're doing is perfectly lawful. They are simply taking advantage of the fact that, until very recently, the United States has been the only major country on earth not to negotiate the cost of prescription drugs. In other words, Novo Nordisk and other drug companies, not just Novo Nordisk, can charge us as much as the market can bear. And that is precisely what they are doing. Now, in a few minutes, when Mr. Jorgensen makes his presentation, and we look forward to hearing from him, I suspect that he will tell us that the healthcare system here in the United States is complex, and that there is a difference between the list price and the net price as a result of the rebates that PBMs receive. And this committee has begun to do some serious work with regard to PBMs. And if he says that, he is correct. But even factoring in all of the rebates that PBMs receive, the net price for Ozempic is still nearly $600, over 9 times as much as it costs in Germany. And the estimated net price of Wegovy is over $800, nearly 4.5 times as much as it costs in Denmark. What must also be understood is that not everybody can take advantage of the net price of these drugs. If you are uninsured, you pay the full list price. If you have a large deductible, you pay the full list price. If you have co-insurance, the percentage of the price you pay at the pharmacy counter is based on the list price. And let's be clear, 75% of Americans, over 190 million people with insurance, are unable to access Wegovy through their insurance policies. Mr. Jorgensen may also tell us that Novo Nordisk is afraid that if it substantially reduced the list price for Ozempic and Wegovy, PBMs may limit coverage for these drugs. Well, Mr. Jorgensen, let me ease your concerns. I am delighted to announce today that I have received commitments in writing from all of the major PBMs that if Novo Nordisk substantially reduced the list price for Ozempic and Wegovy, they would not limit coverage. In fact, all of them told me they would be able to expand coverage for these drugs if the list price was reduced. I ask unanimous consent to insert the letters I received from the PBMs making this commitment into the record. Now, let me share with the committee some other important information that we have uncovered as part of our investigation. Last week, I received a letter from over 250 doctors urging us to do everything that we can to substantially lower the price of these drugs. This should come as no surprise. What these doctors are telling us is that if the price of Ozempic and Wegovy is not substantially reduced, many of their patients who have diabetes and obesity, especially lower-income Americans, often minority Americans, will be unable to afford these drugs. Some of these people, some of these patients will unnecessarily die, and others will suffer a significant decline in their quality of life. I ask unanimous consent to enter that letter into the record. Earlier this year, Dr. Alison Galvani, an epidemiologist at Yale University, conducted a study on Wegovy. And what she found, and I hope Mr. Jorgensen pays attention to this, is that over 40,000 lives a year could be saved if Wegovy were made widely available at an affordable price to Americans who need the drug. 40,000 lives. I ask unanimous consent to insert that study into the record. A few months ago, Dr. Melissa Barber, a healthcare economist at Yale University, conducted a study on the cost of manufacturing Ozempic. And what she found is that Ozempic can be profitably manufactured for less than $5 a month. We all know the cost of production is not the only expense by far for a drug company. Pharmaceutical companies spend great sums of money on research and development to find new treatments, with many of these products not coming to market. We all understand that. But it is important to know that this drug can be manufactured profitably for a few dollars a month. We may hear from Mr. Jorgensen that Novo Nordisk spent $21 billion on research and development since 2018, and I take his word on that. What he may not tell you is that Novo Nordisk spent $44 billion on stock buybacks and dividends over that same time period. In other words, since Ozempic came onto the market in 2018, Novo Nordisk spent over twice as much on stock buybacks and dividends that it spent on research and development. And let's be clear. Outrage over the high cost of Ozempic and other prescription drugs is not a partisan political issue, as I expect every person on this committee understands. It's not a Democratic issue. It's not a Republican issue. I'm an independent, not an independent issue. The vast majority of the American people are sick and tired of paying outrageously high prices for prescription drugs. For example, Dale Folwell, the Republican treasurer of the state of North Carolina, has told us that if he did not discontinue covering Wegovy for some 20,000 state workers in North Carolina, he would have been forced to double health insurance premiums for teachers, firefighters, and police officers in his state, regardless if they needed this drug or not. He would have had to double health insurance premiums in North Carolina. Blue Cross Blue Shield of Michigan also announced that it would have to discontinue covering Wegovy because it was too expensive. And when we talk about differing political views, I will tell you that Elon Musk, not one of my great political allies, recently posted on Twitter, and I quote, "Solving obesity greatly reduces risk of other diseases, especially diabetes, and improves quality of life. We do need to find a way to make appetite inhibitors available to anyone who wants them," end of quote. And Mr. Musk is right. Further, not only must we be concerned about lack of access to these drugs, we have also got to take a serious look at the financial implications of what happens if the prices of these drugs are not substantially reduced. Bottom line, if just half of the adults in our country with obesity took weight loss drugs like Wegovy at current prices, the cost would be astronomical and would have a devastating financial impact on our country and on federal and state budgets. Best estimate that I have seen suggests that if half the adults in our country took these weight loss drugs, it would cost $411 billion a year, $411 billion, and that is more than what Americans spent on all prescription drugs at the pharmacy counter in 2020 or 2022. In other words, the outrageously high price of these drugs could bankrupt Medicare and radically increase premiums to absolutely unaffordable rates. This does not have to happen. It does not have to happen. Over the last several months, I and my staff have been talking to a number of major generic pharmaceutical companies. These are large companies that supply hundreds of millions of prescriptions to many millions of Americans, and what these CEOs have told me is of enormous consequence. They have studied the matter, and they have told me that they can sell a generic version of Ozempic, the exact same drug that Novo Nordisk is manufacturing, to Americans for less than $100 a month. $100 a month. Novo Nordisk charges us $969 a month for Ozempic. These generics can sell it to us for less than $100. Let's be clear. Nobody here is asking Novo Nordisk to provide charity to the American people. Novo Nordisk has already made billions of dollars in profit off of these products, and in the coming years will make billions more. All we are saying, Mr. Jorgensen, is treat the American people the same way that you treat people all over the world. Stop ripping us off. A few months ago, President Biden and I wrote an op-ed which appeared in USA Today. And here's what the president and I said, quote, "If Novo Nordisk and other pharmaceutical companies refuse to substantially lower prescription drug prices in our country and end their greed, we will do everything within our power to end it for them. Novo Nordisk must substantially reduce the price of Ozempic and Wegovy. As Americans, we must not rest until every person in our country can afford the prescription drugs they need to lead healthy, happy, and productive lives," end quote, from the op-ed from the president and myself. That's what President Biden and I wrote a few months ago, and that's what I believe. Prescription drugs in this country must be affordable, and we must not be forced to pay far higher prices than people in other countries for the same exact product. This is especially true when we face a national emergency in terms of the twin epidemics of diabetes and obesity, which, if not addressed with lower-cost drugs, could cost us tens of thousands of lives and an unimaginable amount of money. Congress and the administration have a moral responsibility to act now, act boldly, and to protect the American people.
Ranking Member Cassidy, Senators, thank you for the opportunity to speak again before the Health, Education, Labor and Pension Committee on behalf of Novo Nordisk. Last year, I was asked to testify about patients living with diabetes and insulin affordability. This year, I volunteered to appear before the Committee on Policy Solutions for Patients Living with Obesity and the challenges they face navigating the complex U.S. healthcare system. I appreciate the opportunity to engage here today. For decades, our public discourse about obesity and to some extent type 2 diabetes was based on misinformation and blame. These conditions were treated as a personal choice, a failure of willpower. No one was talking about how these are chronic diseases and treatable diseases. With the discovery of semaglutide and the development of Ozempic and Wegovy, our collective understanding of these diseases fundamentally changed. But this shift was not a foregone conclusion. This was a long and winding road. Today, we can provide insulin to nearly 30 million patients. But patients living with type 2 diabetes and obesity can't wait another 50 years. That is why, since the beginning of last year, we have committed over $30 billion to expand manufacturing capacity. To put the $30 billion in perspective, this is 20% more than the entire US space program. It's also 4 times the amount that Congress has set aside for National Electrical Vehicle Charging Network. Our commitment includes $4 billion in new investments to expand our facility in North Carolina, on top of the $5 billion we have already invested there, creating thousands of construction jobs and manufacturing jobs in the state. We spend these resources because we can't afford not to. Type 2 diabetes costs US approximately $413 billion every year, and obesity costs the US $1.7 trillion. And we all know the physical and emotional toll these diseases make. You have said that our amazing medicines can't help patients if they can't afford them. That is true. It is also true that the full value of Ozempic and Wegovy can only be realized if patients can access them.
It's a very simple question. In Germany, they're paying $59 for Ozempic. In the United States, we pay $969. And again, even with all of the discounts, we are still paying very substantially more than the people of any other country. And you are selling, as I understand it, 72% of your revenue comes from the United States. Is that right? Roughly?
If it's based on our accounts, you're right. I don't have the number from the top of my head.
So you're making huge amounts of money in this country and you're charging us far more. And you haven't given me an answer as to why. Let me ask you another question. A recent study from Yale University has estimated, as I mentioned earlier, that 40,000 lives in America could be saved each and every year if Novo Nordisk substantially reduced the price of Wegovy and made it available to everyone who needs this drug at an affordable price. From a moral perspective, does it bother you knowing that keeping the price of Ozempic and Wegovy so high in the United States could lead to the preventable deaths of tens of thousands of Americans?
So, Senator, we are very committed to make sure that Americans have access at affordable price point for our medicines. There is no thing we would rather see happen. We have just announced 30 billion investments to increase capacity to serve these patients. There is a market we have to operate in, and we negotiate hard to make sure that Americans have access. We negotiate against the PBMs and give them significant rebate discounts and fees.
Mr. Jorgensen, you're not answering the question. And look, as you may know, I'm a great respecter of the people of Denmark. I think you have a social system which is very progressive. But I'm asking you a simple question as a decent human being. What studies tell us is that because of the very high price of your products, 40,000 people a year may die in America. And you have not. Increased production is fine. But what I am asking you is, if you don't act, 40,000 people a year could die. Is this acceptable to you?
Senator, any prospects of patients not getting access to the medicine they need, I think is terrifying. And we have to solve this challenge together. I mentioned in my opening that I don't think any one company can solve that alone. I wish there were more at the table today so we could have a discussion about how we do that together. We don't decide the price for patients. That's set by the insurance companies. I do acknowledge that there are patients who have poor insurance or no insurance. And if you, in the US, do not have insurance, if you have a low income, we actually have support programs to help those patients. I'm proud about those, but they are not a real solution because patients should have access to medicines via insurance, because if you live with a chronic disease like type 2 diabetes or obesity, these are complex diseases that requires access to physicians. There are comorbidities you need to have treatment for. I strongly believe we need to solve this within insurance. And when you are in insurance, there is access to our medicine.
Well, Mr. Jorgensen, this committee has heard from insurance companies. We've heard from PBMs. We've heard from everybody in the world, and everyone blames everybody else. But you still have not answered my question. It's a very simple question. Why Novo Nordisk is charging Americans substantially higher prices for these drugs than the people in other countries. Let me get to another issue. Mr. Jorgensen, you have told this committee that you are concerned that if you substantially lowered the list prices of Ozempic and Wegovy in the United States, PBMs may take these drugs off of their formularies and deny access to patients who need these drugs. I think you used insulin as an example of that. However, I have received commitments in writing from the major PBMs that if Novo Nordisk lowered its list price, they would not limit access to Ozempic and Wegovy and would not take these drugs off of their formularies. Given this fact, will you commit today that Novo Nordisk will substantially reduce the list price of these drugs in the United States so that the American people are not paying higher prices, far higher prices, for these drugs than the people in Europe and Canada?
So thank you, Senator, for that information. That's new information for me. Anything that will help patients get access to affordable medicine, we'll be happy to look into. I'd just like to make a comment also that the experience, as you also allude to yourself, from insulin is one of when we had a discussion last year in the hearing on insulin, we actually lowered insulin pricing. That had a consequence. So when we dropped some of the insulin prices, we had our products dropped from formulary coverage. So less patients got access to those insulins. So I have a bit of concern how this could play out. But anything that can help patients get access to the medicines they need at affordable price point, we'll be happy to collaborate around that.
Are you prepared to have Novo Nordisk sit down with the PBMs who have made that commitment to me that they will not take your products off of the formulary, sit in a room with us and work on an agreement?
I'll be happy to, as I said, do anything that helps patients. And I don't know under which conditions such a promise comes. I haven't seen any of that.
Okay, I will get you they're in writing, and I'll get you the letters.
The fact that we do the R&D, why don't you charge them more to where there's at least not a 10-to-1 differential, to where you share the costs across the world, not put it on the burden of a place that's now borrowing 30 cents on every dollar for whatever's provided through government, and to where you're jabbing it through the private insurance side. Why is there that kind of difference? Why don't you charge them more in Europe?
So, Senator, we might also do that in the future, but actually the price differential you mentioned is not the real price differential. I think that's part of the problem, that we are not charging as much in the U.S. as you...
I think you're hiding behind your opaqueness, and you need to promote transparency for your own good. It'd be easier to understand. Thank you, Mr. Chairman.
Thank you, Senator Braun, and thank you, Mr. Jorgensen. Let me just make a few remarks. Senator Braun and I come from different perspectives, but occasionally we agree that the system is broken. Senator Braun said the industry is screwed up. Is that the correct quote? I don't agree that it's screwed up. It's enormously profitable. This is a company that makes huge profits. Top 10 pharmaceutical companies made over $100 billion in profit last year. It's not screwed up. They are making huge amounts of money. And I think, Mr. Jorgensen, you were not quite correct when you talk about 79% rebates on Ozempic and Wegovy. That may be in general. My understanding, it's a 40% rebate. I believe that I have heard that in fact, the product, that after all of the rebates from the PBMs, your product is about, for Ozempic, about $600.
Can I clarify that?
Please.
So our price has gone down by 40% since launch, and already when we launched it, there was a significant rebate. So the rebate has gone up by 40% since launch, on top of a launch rebate.
All right. My understanding is that factoring in, and we all agree it is a complicated and broken system, I would point out, and you correct me if I'm wrong, Mr. Jorgensen, that in your beautiful country, Denmark, anybody can walk into a doctor's office, go to the hospital. How much do they pay out of pocket?
In Denmark, we have, say, a healthcare system that is tax paid.
Yes. How much does an individual pay out of pocket? If I'm in the hospital in 2 weeks in Denmark, how much do I pay out of pocket?
To go to the hospital?
Yeah.
Zero.
Zero. You go to any doctor? Zero. And you are spending a little bit more than half as much per capita as we are. So they provide quality care for all of your people, and almost half of what we do. All right. That's a simple system that, to my mind, makes sense. We have a complicated system, not only in healthcare, but in prescription drugs as well. But the point that I want to make is that factoring in all of the rebates, we heard a lot about rebates, I agree with much of the criticism, factoring in all of the rebates that PBMs receive, the net price of Ozempic is still nearly $600, over 9 times as much as it costs in Germany. And the estimated net price of Wegovy is over $800, nearly 4.5 times as much as it costs in Denmark. And I know Senator Romney, others said, well, how is that so? Why is it so much less expensive in Europe? And the answer is obvious. In the United States of America, we are the only major country on earth that has not negotiated prices. So you can charge us any price that you want. Other drug companies can charge us any price that they want, as much as the market will bear, and that's what you do. Understandably, you charge us far more than other countries because they negotiate and regulate prices. Now, the good news, and I share the concerns and the skepticism about PBMs, but we have, as I've mentioned to you and will share with you, statements from the 3 major PBMs that they would not penalize Novo Nordisk in terms of formula placement if you substantially lowered list prices. And I look forward to sitting down with you, your representatives, and the 3 PBMs to make sure that that happens.